why is it all necessary? It's not. It's just an epiphenomenon.
So what do you think about the brain's ability to help reduction of stress chemicals in the body? So the thing that the brain ability to reduce stress chemicals in the body helps control of the intensity of what we call pain. So this quote does not apply to the pain, descending pain inhibition, or if you like better, to descending nociceptive.
Okay, yeah. Some people are pretty good at it. For example, you know, the Iceman, the Dutch Iceman, Wim Hof.
Yes.
Have you seen him? Like this guy, he climbed the Everest like without a shirt, without like anything. He just climbed Mount Everest. And some people are really good at it. For example, Tibetan monks and all sorts of Shaolin monks, they're pretty good at controlling those brain mechanisms. But then again, even if you talk to Wim Hof, he will not say that he never ever feels pain. He would say, yes, I feel pain, but when I start experiencing pain, I will do this and that. I will start doing meditation. So it's not, again, like I said, it's not a bulletproof mechanism. But yeah, you can learn to control it. For example, yeah, some people are good at it. Some people are probably not so good at it. Okay.
And in this way, because there was another photo I saw yesterday, you were quoting the other days about pain is the brain's opinion of how much danger you are. And once you accept it, you can begin to change that opinion. That
I don't
didn't buy that. Huh?
I don't understand this sentence. Like, what do you mean? How does my brain?
It's probably like what I told you. At a certain level, you can maybe modulate the descending perception.
Again, what did you say? You said you, right? You didn't say my brain, because
yes,
like, again,
if you divide, it's like brain is one person and you are the other person.
When you say you and your brain, you are separating both of them.
Yes,
I am my brain.
I order my brain to do that.
Now, like you say, pain is the brain's opinion. That's very insulting. It's like, it's almost patient blaming to me. It's like you choose to have pain. Like, I choose to have pain. Like, if you would say that to a patient, they will never come back to you, you know? Like, so that's why I don't like all those pain neuroscience education messages. I don't like them anymore. I don't, it's like logically, they don't make any sense. Like, your brain's opinion or your brain decides.
Yeah, okay.
Do you think your brain decides anything for you, or is it you that makes the decision? Exactly. Who is you and who is your brain? Are they two different persons? It doesn't make any sense.
It doesn't make. So what actually can the brain influence consciously? Can we do, for example?
We just talked about it. We just talked about it. For example, we gave the example of Wim Hof. Yeah, you can consciously attempt to affect nociceptive processing. You can do it. And as I said, some people are better at it than others. I think that anyone can learn it to a certain extent. It appears, I don't know, I suspect that some people are a lot better at it. And I suspect that the earlier in life that you learn to do it, the better you will be at it. And the later in life that you start doing it, the less better that you will be at it. Okay. I tend to think that, yeah, like, so, like, if you start practicing those things as kids, because, for example, Shaolin monks are excellent example. If you look at them, they start training from age like 4 or 5, and they become pretty good at it, at consciously controlling those descending pathways. But then again, I wouldn't expect an 80-year-old grandma to be able to do that. Like,
that's right.
You know, like our patients, you know, like some of them, like, you know, like are 70, 50, 60 years old. I wouldn't.
They also don't have the physical ability to adapt.
Exactly. Yeah, like, so yeah.
In this way, we can conclude that, for example, we can actually, our brain in certain circumstances can they can modify or influence the motor behavior. So I'm doing weightlifting. So I have somebody says, go for it, try more, and give me some more repetitions, for example. Or can we also say that the perception or sensation facilitates?
Yeah, cognition.
Yes.
Cognition or conscious cognition can affect descending pathways. We know that because, like, even when someone is talking to you, it's like an input, like it's a stimulation,
Yeah.
and stimulation can go downwards, like, and yeah. So cognition, but then again, everything is like should be accepted with a grain of salt, because it's not a feasible mechanism to control pain in the long term.
In the long term, okay.
It's not. So on the short term, yeah, there are a lot of ways you can affect your descending modulation. And again, you can practice it and you can become better at it, but you can also practice it and not get that good at it. So.
Does it also, if this mechanism can affect the secretion of different substances, thus affecting the immune system as well? I mean, the brain, let's say, by actively, consciously trained, can also affect the immune system, and at what level?
Yeah. Like, yeah, we know that exercising, for example, regular exercising is very beneficial for the immune system. Okay, our immune system, it needs also it needs stimulation.
Yeah.
And a lot of activities stimulate, almost like people, like, again, like people need to realize that almost everything, like our immune system is constantly active, always. Like even if I'm now gonna stretch my fingers really hard, like, again, like the immune system will be facilitated, because like that's physiologically how it works. And also we need to stimulate it and introduce new stimuli. And for example, that's what they do with the immunizations and booster immunizations. They reintroduce the same substance to re-stimulate the immune system. And again, exercising also stimulates the immune system. And the better and more exercised your immune system in responding to new stimulants, the healthier probably you're going to be. And again, any failure of this mechanism is usually related to a lot of bad habits, like smoking, being overweight, eating very bad food, not exercising enough. So, like, again, eventually, if there's one important message that needs to get out of this lecture, is that probably the most important things we should address are being overweight, smoking, and not being active enough.
Yeah.
Especially for people with chronic pain. This is like this is stuff that we can, like physiotherapists or other body workers and stuff like that. We have an ability, because we see those people for long times and for long periods, and we should try to address those, because these are the best options we have today to manage chronic pain states.
Yeah, I agree. So in this way, for the example we see with patients that are diagnosed with arthritis. So we have examples with people in certain joints, for sternoclavicular, peripheral joints, have a minor pain all the time. So the pain is there in arthritic joints. But once they start working, the pain is gone. Working, I mean, with training.
Yeah, I wish it was true. Yeah, but usually, for example, like I love the bicycle.
Yeah.
I love putting people on bicycle. Like I put people on bicycle, and I like it because they reach very fast. They reach what I call an aerobic effect. And we now know that the aerobic effect is associated with a lot of beneficial anti-inflammatory responses. And people in their daily life, they hardly ever reach an aerobic effect, especially people nowadays in the modern world. Like people, they see it a lot. They hardly ever raise their heart rate. They hardly ever sweat from exercising. They hardly ever find it difficult to breathe from exercising. Like I ask people, are you physically active? And they will say, yes, of course, I walk every day. And I tell them that's not enough. And they say, what do you mean? I say, you're probably not reaching an aerobic effect. And then I put them on the bicycle, and within 5 minutes, they're starting to breathe like that. And they start to sweat, and they start like their face becomes red. And I tell them, you see, you never reach this ever in your daily activities. And we know this effect is very good. And like people with arthritic joints, they respond very well to this, like moderate aerobic effect. That's what I've noticed. And there is also some evidence to support it, like low impact aerobic activity in osteoarthritic joints is very beneficial. There are some systematic reviews that support that. And also clinically, I see it as very beneficial. So today, almost every patient with chronic pain that comes into my clinic, I put them on the bicycle. Okay. And I tell them, and I even recommend them to buy bicycle for home, like especially if they're older, like older adults, you know, like 50, 60, 70-year-olds. Tell them, buy a bicycle. It doesn't cost that much, and it's such a good exercise. It's so easy, and it's a shame that they don't do it.
And it's probably because it stimulates the whole pain, pain inhibitory mechanism.
Nociceptive inhibitory mechanisms. Yeah. It's like, so again, it's not a miracle. It's not a cure, but it does help them to alleviate, like if they're in a flare-up, it helps alleviate the flare-up. It helps lower down their pain levels. It's not optimal, doesn't always work, but I find it that it usually works. Usually. So
I say very often in the courses that the goal of physiotherapy in terms of rehabilitation is not the goal actually. The way to achieve the goals of being more functional is the gradual exposure to painful stimulus or to the problematic movement or to the restored movement. So we see, for example, when you have a person who in a certain, let's say, external rotation pain, and the more you go and work there and you touch the pain by, let's say, 2 or 3 out of 10, after a while, the pain decreases, desensitizes.
Hopefully, I hope. I don't know, like, I'm not sure I agree with that. I tend to think maybe, but some people, like, you know, maybe in some patients, maybe in a lot of patients, but not all. I don't know. Okay, but for example, the example of the bicycle is not really that. For example, because for example, people with knee arthritis, they find it very difficult to load it up. But then again, bicycle is like without any weight bearing. They find it really easy. It doesn't provoke them, and still it helps without exposing them to the active nociception. They still react. So I don't know if it's really necessary to actually gradually expose. I think we can reach it via other ways. Okay, because again, like, bicycle is excellent.
Well, what I've seen in many patients clinically, and it's a wide spectrum of ages and problems and symptoms, area symptoms, is that when you just respect the irritability of the patient. So you have a patient that you don't go, let's say, out of 2 or 3 out of 10 in the pain scale, and you just go there and slowly do a very controlled movement that you can really change if something goes wrong. Usually they improve, and they improve really very, very, very good. I remember a lady over 100 kilos. She could not step on the stairway. And I just put her against the wall with a big ball in her back, and she just started slowly squatting. After a while, she could walk up and down the stairs with no pain at all. And I would like to see if there is a mechanism proposed for that. How can say that this gradual exposure to a very small pain can really? It's the same when you do a mobilization of a a joint that doesn't move. You go over the resistance, but usually the resistance of the joint is painful. So you reach there and you gradually try to increase the movement.
There could be many possible mechanisms that I can try to explain it. Again, eventually it goes down to probably a combination of it, and it can be one mechanism, and it can be a combination of few mechanisms. Like, for example, one, I don't know, like first is the descending inhibition. The second could be like she realizes that when she does it in a certain way, it's not that bad, and that's a cognitive mechanism, like, and then she becomes more relaxed, and she's saying, oh, it's not that bad. So there could be many different mechanisms, and maybe possible many that work together. Okay, but eventually like the most basic physiological explanation that we have is descending inhibition. For most of those things, it's usually there, and you can superimpose some other mechanisms on it also.
What's your opinion about the DNIC, the diffuse noxious inhibitory control? My latest experience clinically was a patient of mine who could not perform a flexion pattern movement with her hand because it was stuck here, like it was not moving correctly. And when I put a needle on the other hand here, which is a very painful spot, immediately she would move it.
Yeah, that's like like what you said, the NIC, diffused noxious inhibitory control. And we also know that the further away the stimulus is from the location of the
initial pain, let's say,
of the initial of the pain or stuff like that, the better it is. So, for example, if you say it's like on your left hand, if you will put a needle in the big toe of the right foot,
yes,
like the further it is away from there, the better the better it will be, the better it will work. Like they test this paradigm in a lot of pain experimental pain studies. They call it, I don't like this name because again, it's not really, it doesn't reflect what is being done. They call it conditioned pain modulation, or CPM, but it's not really a conditioned pain modulation. It's introducing a noxious stimulus.
So you agree more to the DNIC terminology, diffuse noxious inhibitory.
I think the former name, the NIC, is more appropriate, or counter irritation analgesia.
Yeah.
Okay, you introduce a counter irritant, and again, so the further away the counter irritant is from the place of complaint, the better it is. Yeah. So, for example, pain in the jaw here, again, like try to stab the pain in your left jaw, then stab the right big toe on the right foot. Okay.
Yeah. And when we do a technique with our hands, so you have a painful movement in the lumbar spine, like pain in extension and side bending in one part. We have moved away from the explanation that when we put our hands in the L5 on the left side, we are turning or rotating or whatever. But you still have an analgesic effect, which is lasting. So there is, for example, I have a patient, side bend to the right and extension, makes pain on the right part of my low back, let's say where the L5 is. So I put my patient and do a PA on the left, on the other side. And I know that I'm not rotating anything. I'm not actually moving any bone there. But still the patient feels better after a while. And this pain reduction is maintained. My patient gets better gradually with the days.
Again, the underlying mechanism, again, is a descending inhibitory control.
Yes.
Again, this is in almost any form of therapy, this is the main mechanism that is always present. Others are superimposed on it. So
when you speak about descending inhibitor, you speak that the brain is doing something, or it's at the spinal cord level that is doing the inhibition? Because I give only mechanical stimulus, nothing else. The only thing I do is I give a mechanical stimulus.
It's, as I said, it's both. Okay, both. It's like both.
But we really don't know what happens there when I do the pressure there. What happens?
We have a good idea of what's going on, but yeah, we have a good general idea about what's going on, but it's
what
a general
about, for
idea.
example, what about the explanation that says if I have pain on the right side, I have some receptors there sensitized. When I go on the left side, I don't have sensitized structures. I don't know which structures, but there are some structures probably. And on the left side, what I do is actually use the gate control explanation of pain reduction.
Again, yeah. It's, as I said, it's a part of the mechanisms. Like, again, descending inhibition is always going to be there when there is human-to-human interaction.
Okay, right.
Like, this is what we call the contextual effects and stuff like that. Whenever you go to a therapist, you're going to have descending inhibition because that's a cognitive effect. The contextual effect is cognitive. It's like your expectations from it are always going to be there. We cannot isolate it, and we can never get rid of it. We can, in experimental studies, we can somehow control it. We can attempt to control it, but we can't eliminate it and we can't get rid of it. But it's always going to be there in human-to-human interaction, always.
Okay, so
it's always descending inhibition, always. It's the first mechanism that is always going to be there.
Okay. One of the last things I want to talk to you today is what about the diagnosis of neuropathic pain? Actually, what are the tools we use to say that this person has a neuropathic pain? It has to be an injury in the system, in the neural system somehow.
First of all, it's a very typical. It's the very typical complaints of related to nerve tissue.
Ectopic impulses, like
not the symptoms they describe. Like, it feels like ants on my skin. It feels like electricity. It feels like first of all, that's like the first clinical indicator that there might be neuropathic pain, or yes, it burns like so, like it feels like I'm burning, or
like thunder coming in my nerve, like
that's the typical clinical indicators of neuropathic pain. And then the second stage is neurophysiology. You send them to like nerve conduction testing, and they affirm that there is some sort of reduced conduction. That's another indicator. And then you send them to maybe nerve biopsies or MRIs.
Laser evoked potentials.
What?
Laser evoked potentials.
Laser evoked potentials?
Yeah, I think Max Zussman referred that some years ago, the laser evoked potentials to diagnose. I don't know this.
No, again, like the way to diagnose neuropathy is eventually via MRIs, electrophysiology. Yeah, that's the way you confirm there is a neuropathic pain. And neuropathic pain is a condition where we know there is actual damage to nociceptors or the nervous system.
And yes, you have to have a damage in the nerve system, and then also that they become the sources of ectopic impulses.
Yeah, exactly. So some people with neuropathies, and for the viewers and listeners, ectopic activation means activation from somewhere where it's not supposed to be activated.
Right.
So usually nerves are activated at the synapse.
Yep.
Okay. But when we talk about neuropathic pain, you can have damage to the axon itself.
Yeah.
The ectopic activation is from somewhere in the middle of the nerve and not from the synapse. Like the area of damage in the axon itself is what activates the nerve, and this is an ectopic activation, and it's a pathological condition, and it's not supposed to happen like that.
And as physiotherapists, what is our chances to treat this kind of pain? I think we have limited
again, the only possible way that we have to tackle it is through aerobic exercising.
Yeah.
Aerobic exercising, and again, unloaded aerobic exercises. I think it's beneficial for most people at the beginning, and later if they can add up like loaded, like running or other stuff, like then it's okay. But they need to do persistent aerobic workout to reach this aerobic effect that can lead to all those beneficial anti-inflammatory processes that we want to encourage.
What is the role of long-term potentiation in all this kind of chronic pain?
Long-term potentiation, again, it's a physiological process. In the beginning, if it persists, it becomes pathological. Again, we know that, yeah, like it's easily tested in animals. In humans, we don't really have any way to test if it's actually going on, because in animals they can record, the initial state and the end stage of the experiment. Like, but it's a possible mechanism. It's a possible mechanism that. Yeah.
If we think about long-term potentiation and we try to do it, I don't know if the word is correct, as a metaphor to people, is it the long-term potentiation, the fact that I feel having pain every day, which is creating or a long-term potentiation, or this is not the same?
Again, as I said, like neuroimmune activation, molecular activation can cause long-term potentiation.
Okay, and also be by immune system. So actually, the longer you get pain, the more long-term potentiation state you are in.
Probably, yes. Yeah. And again, it can happen not physiologically. It can happen pathologically, but it can also happen, from as I said, molecular mechanisms.
Okay, very good. And what does the term nociplastic tell you?
Oh, I think it's a very important term that was introduced. There was a lot of pushback in the International Association for Pain against this term. There are people who don't like it, and I'm from the ones who think it's a very, very important term.
Okay.
Because it provides a frame for all those unaccounted for, unexplained pains. It finally provides a frame for them. Okay.
Like, it's not like a bucket for things we don't know.
Yeah, because like pains that are not nociceptive and pains that are not neuropathic. And so for patients, it's a very important term because it gives validity and legitimacy to their complaints. Because until now, there was no framework for doctors on how to process this complaint, like a complaint of pain that, well, I see no damage, no tissue damage. I see no nerve damage. So therefore your pain is in your head.
It's not a chronic pain. It's not synonymous to chronic pain.
It's not synonymous to chronic pain. It's a term used for all those pain states where that don't fall into either the neuropathic descriptor or to the nociceptive descriptor. And so now we have this term that acknowledges that these people have an actual biological problem, okay? And before that, there was no framework for that. So
could you give an example of which kind of patients would you categorize as nociplastic?
Okay. Fibromyalgia, for example, most of them will eventually be classified as having nociplastic pain because their nervous system is apparently intact. You do nerve conduction velocity studies, and they have normal conductivity of nerves, and you and you do the MRI and you don't find anything in their nerve, so it's not neuropathic, and there's no sign of tissue damage, so it's not nociceptive. So they fall into the nociplastic pain.
But excuse me to interrupt you. Nociceptive does not mean, is not always with synonymous with tissue damage, or is it?
When you have tissue damage, it is synonymous, but it can also be synonymous with pain that you can actually find the noxious stimulant.
A chemical stimulus.
Chemical is not that easy to find, but for example, if I stab you with a knife, I say, well, now you have.
Yes, you have a chemical too.
Yeah, but it's pretty sure that, like, I know what the I know what the noxious stimuli was. I know that the knife was the noxious stimuli, so I could say that's nociceptive pain. Eventually, if I injured your nerve while I stabbed you, you might have neuropathic pain.
Yeah. So you say, probably if I understood correct, that nociceptive pain with tissue damage are binded.
Nociceptive pain with tissue damage, yeah, it's kind of like if someone comes into the clinic right now and he has a huge open wound,
yes, that is definitely
pain, that is definitely nociceptive.
But not always nociception is related to tissue damage, if I understand correct.
As I said in the beginning, noxious stimuli are not necessary for pain. And I don't need to stab you with like, it's acknowledging that I don't need to stab you with a knife for you to have the experience we call pain. You can have an activation of the apparatus via molecular mechanisms for you to have pain. Okay, and I don't see it. Like I'm looking at the blood tests and I don't know how.
There's nothing there. Yeah.
But I acknowledge that it can happen. That's why the term nociplastic is very important. It's very important clinically for patients.
It reminds me on the bucket that says non-specific low back pain. We know you have pain, but we don't know from which structure does it come. In the same way, so nociplastic is, we know you have pain, but we cannot explain it because you don't have, let's say, nociceptive input, and you don't have also neuropathic.
Yeah, so a lot of people with non-specific chronic low back pain can be classified as having nociplastic pain. And again, I acknowledge that they have a problem in biology, and I acknowledge that I'm probably not that good at finding it. Okay, the term is defined as the presence of altered nociception. Now, altered nociception, again, is a postulated mechanism. And again, we have evidence for that, especially impaired neuroimmune cross-talking can account for that. Okay, it alters the nociceptive functioning. So I think that this term is very important. I think that this term has good preliminary evidence to support its introduction into the vocabulary of pain medicine. And the people who don't like it are the basic scientists, but then again, basic scientists, they find it hard to agree on almost any definition of anything. So I don't know.
Yeah.
But for clinicians, it's a very important term, no doubt about it.
So I have a last question for you. There is a video on the internet, and there is a guy, American, he's a dancer. He had a rupture in Achilles tendon. So he describes that one day he was walking to go to his work, and he stepped on an acorn, and when he heard the crack, the noise, he felt on the site of the injury a sharp pain. After a while, he did a couple of steps. The pain was gradually reduced, and then it stopped, maybe 5 steps later, and never came back. So what about the memory of pain, or what is called memory of pain, and this experience? How you would say that the experience he had, how do you relate and how do you explain this fact? So I stepped on an acorn, I hear the noise, it reminds me of my injury. I have pain, sharp, some seconds later it's gone.
Well, all those stories are anecdotal, and there are many stories like that, but again, I don't buy this idea of a memory of pain that keeps on going on and on and on and on and on.
Well, it stimulates the memory of an experience, stimulates a response that creates a sudden crosstalk of immune. I don't know how to explain that.
Okay, like even if I, okay, for example, like, have you ever experienced someone who kicked you in your testicles, or did you ever get hit in your testicles? If you think about it now, do you think you can relive this experience like exactly like how it was? I doubt it.
No. But
yeah.
I remember one time, another thing, that I remember somebody who had really pissed me off. I was sitting on my desk just like that. And only by reminding or remembering a person that was really pissing me off, I had a low back pain immediately without anything.
Okay, but maybe like, okay, so you can still reconcile it with nociception. You got angry, you got really strong immediate muscle spasm.
Probably,
okay?
yes.
Okay, and you actually had actual nociception, so it doesn't necessarily have to be a memory of pain. You know what I mean?
Yes, there is a connection between the stimulus was with a thought that stimulated the apparatus.
So maybe this guy, he stepped on the nut and like it reminded him, and he consciously contracted really hard his muscles in the foot.
He did not say contractions. He only said I felt pain at the site of the injury.
Again, I'm saying there are still ways, like, again, he may not have recognized it, but I can find ways to reconcile it with actual nociception that happened.
Yeah, probably.
Okay?
Probably the apparatus is there.
So again, I don't buy the idea that you can have a memory of pain.
Okay.
Because once we start getting into this idea, we are getting ourselves into a logical problem. Because then you can say that every pain is a memory, and how would you test if it is a memory or if it is actual pain? You will have no way to distinguish between the two, you know? Like, okay. And so the idea of a memory, like, you know what do you understand what I'm saying?
I think I get it.
Think about it. If like you start saying, oh, memory of pain is true, then I need to have a clinical criteria for diagnosing memory pain. Now,
deep waters there.
How are you going to even test it? It's untestable. You cannot. Okay.
Well, the only thing is
the only way is to try and reconcile it with nociceptive explanations. For example, there is this anecdote of the nail in the boot guy. That's an anecdote. And a lot of people are citing this anecdote, which was in the BMJ. Okay, it's a case. It's not even a case study. It was just like a paragraph in the
journal, in the paper.
It was not even a case study. It was just like a small description in BMJ of this guy that like had a nail in his boot, and he came to the
emergency. They gave him fentanyl.
What?
He came to the emergency and they gave him fentanyl to remove the shoe.
Yeah, because he was screaming from pain. And then when they removed the nail and they removed the boot, they saw that the nail went between his toes. And people say, oh, this is a good example of how you can have psychological pain or pain just by thinking about it. And I say, really? Like, come on, have you ever had like maybe the nail pressed hard enough against his toes, and that can be painful. And again, if we think about the definition of pain, the definition of pain includes a part where it says actual or potential tissue damage. So a nail that is pressing your skin, your webbings of the toes hard enough and not injuring it is a possible tissue damage. Okay, so
which involves other mechanisms as well.
Yeah, you can pinch yourself really hard and have pain yet without any tissue damage. So it's potential tissue damage, and it is in the definition of pain, actual or potential tissue damage. So I say this guy had potential tissue damage and he had actual nociception happening. The same in your case, where you got angry, you got so angry that you, I don't know, you could have made like a really hard spasm in your back, and that spasm again is actual nociception. So the memory, yeah, it triggered a nociceptive reaction, nociceptive chain, but there was actual nociception there. There is no way to scientifically reconcile the idea of memory pain. There is no scientific way to reconcile it.
So is the trigger that is by memory activated? You trigger, or you activate the apparatus?
Yeah, you can only reconcile it with an actual activation of nociception. That's the only scientific way to reconcile it, because once you start having, you're saying that, yeah, you have memory pain, then now any person can have memory pain. You know what I mean? Any pain can be a memory pain. And how are you going to test it?
So you can only say that, for example, an example like that is that through a memory or through a thought or something like that, which is not a tissue related, you just activated the whole apparatus. And at the same moment, it can be that you lower the threshold of pain, let's say, or whatever, that activates the whole process.
You somehow activated the apparatus,
But it's the apparatus that is nociceptive and it's activated. That's the main issue.
That's the main issue. You cannot just like, because if that were the case, then why can't I just create pain by mere thought alone? I want pain, I want pain in my shoulder right now. Why can't I do it?
Yes, this is a very good example.
Yeah, I want to be able to create pain in my shoulder right now.
Yes.
I'm thinking about it and it doesn't happen. Why doesn't it happen? Because we have some sort of bufferings that are working all the time. And sometimes those bufferings break. And when those buffers break, we get activation of the apparatus.
Plus something else. If you reverse the effect, you have a patient with pain. If it would be like this, I would order him to stop having pain and would be successful.
Exactly. Or if that was the case, then theoretically, most psychological treatments should have been effective, but they're not.
Yes, it's very good.
So again, there are no scientific way to accept it. It's like, because now anyone that walks into my clinic can have memory pain. Oh, it's just a memory of like this trauma that you have, and that's why you have chronic knee pain now for 20 years.
Or if you replace with another memory, maybe, but it doesn't happen like that.
It doesn't work like that. That's why I don't buy those ideas, and I think they're very bad, and they're like they're very bad for the profession. Like, it's just like they're unscientific. They're bad for the profession. They're bad for patients.
Yes,
who are told that. This stuff is the epitome of unscientific.
So if we conclude our today's discussion, we say that first of all, you need to have nociception to have the pain experience, and you can trigger the apparatus by different ways. It can be mechanical, it can be chemical, it can be also, let's say, psychological ways of triggering. But if you have pain, the apparatus has to be there, and this is the one who brings all the experience of pain to be activated.
Exactly.
That's very important. Also, the other thing is that at the moment we are probably far from treatments to be able to really deal or to extinguish, let's say, all kinds of nociplastic pain like fibromyalgia. And the only thing we can is to do active movements and whatever can break the circle. Yeah,
that's a good summary, I would say. That's a very good summary. But I think that by acknowledging that there is an apparatus, we are at the beginning of an actual breakthrough.
Yeah, I believe. And to break the circle, you can use everything legitimately. I mean, you can use massage if somebody likes massage. You can do hands-on techniques. You can do training. You can do joking. You can say jokes also. If you just break everything that contributes in the pain experience, it should be a tool for us to try to do the best we can.
In the meanwhile, that's all we have.
Okay.
Meanwhile, but I'm sure that 20, 30 years from now, we will have major breakthroughs, and chronic pain some chronic pain states will be a thing of the past. And when that gets here, I always say that this is my doomsday prophecy. physiotherapists will not be treating chronic pain anymore.
Yes. Well, in this time, maybe we'll be old and somebody else has to treat us.
Yeah, but then again, we will have better medications by then.
Yes. So it was a really pleasure today, Asaf. Thank you very much.
Yeah, it was good talk. Yeah.
I hope, yeah, it was very productive, and I hope to be able to talk again for new topics.